All right, welcome back. Al Smith here. That's a song off the latest Southern Hospitality record, or I should say the first, and that was Victor Wainwright on the lead there. I am talking with Dr. Brian Hatten here, and we're talking about orthopedic surgery. And when we first talked the other day about you coming on, you were real excited about a new procedure, some new things going on in your world, and hip replacement, right?
That's right. Yeah, the things that we were talking about has to do with the difference in approach to hip replacement. Hip replacements are one of the most common orthopedic procedures that are performed in the United States. It's estimated probably over 300,000 of them are done every year in the United States alone. Wow. And it's been a real game changer in restoring function back for patients.
And with an aging population, I got to add, that number's only going to go up.
Oh,
right?
Absolutely. The estimates are incredible as far as the number of procedures that will likely be done just by 2020 alone. And because of the longevity of hip replacements that we're finding now, they're actually getting done even in younger patients than it used to be in the past, which means, of course, now there are more patients that are potentially have a viable option of having a hip replacement earlier. Hip replacements have been around for quite a while, about 50 years or so, and the results of them are really excellent. What we were going to talk about has to do actually with the approach to getting to the hip, to do the hip replacement. Over time, the components have gotten better and better, and now we are using ways of getting into the hip that are less traumatic than they used to be. Traditionally, most hip replacements have been done with what we call a posterior approach. And what that means is the surgeon will make an incision towards the side and buttock region and access the hip by going behind the thigh bone. And when we do that, we have to take down some tendons and split some muscles in order to get there.
Sounds painful.
Well, it does lead to a little bit of pain because the access requires a little bit more dissection into the soft tissues. Now we are using an approach called an anterior approach, and which means the front. So we make the incision on the front now, and we can get into the hip by actually just swiping away the muscles and moving them to the side and get direct access to the capsule and to the hip joint itself without detaching any tendons, without cutting any muscles. And it's very exciting because it's led to a lot of improvements in not only patients' recovery but other surrounding issues that we've been able to fix compared to the posterior approach.
Now, is that because of the equipment you're using, a piece of equipment?
A lot of it has to do with equipment, and equipment in twofold. One is the equipment for putting the prosthesis in has become much more sophisticated and has been specifically designed now to get to this specific approach. And the second is because of a table, or actually two tables that we have over at Halifax, to allow us to position the patient appropriately and get real good access to the hip. This is the reason, really one of the major reasons why we haven't done this approach that much in the past, is because we didn't have real good access to get to the hip very well from the front. But now we have some very specially designed tables that the patient will lay on that allows us to put their legs in the right position in order to accomplish the surgery through real small incisions and very minimally invasive. Some of the other benefits is this table that we use, one of them is called the Hana table, the other one's called the PROfx table, is that we can use a live x-ray. So I can actually have fluoroscopic machine come in during the procedure, and I can take a x-ray picture of both of the hips, of the good hip and of the hip that I'm operating on, and I can line up all the components exactly how they need to go, and also approximate the leg lengths to make one side equal to the other side, which is an improvement over the technique that we used when we were doing the posterior approach significantly.
Wow. So is that like a 3D thing? Is it?
No, it's still two-dimensional. In order to obtain 3D, you have to use a little bit different sophisticated equipment, such as a CAT scan, but that's something that's not necessary during this procedure. Essentially, what we're looking at is the landmarks on the bones, and we want to align those landmarks up with the prosthesis and create the exact right lengths, and we can do that by using the live X-ray and comparing one side to the next. And what I mean by this is when you put in a hip replacement, there's a couple of different ways that you can affect the length of the leg. Okay. First of all, when you have an arthritic process and you have bad arthritis in that hip and you have that bone on bone that we were talking about a little bit earlier, that hip usually will be shorter because you've lost that cartilage cushion, because you've developed some deformity in that area. And once you have that shortening, that creates what we call a leg length discrepancy. Some patients will notice it. All of a sudden, their leg just seems to be shorter than before when they've developed that arthritis. The hip is made up of ball and socket, and we remove the ball, and then we replane the socket. So we place a new socket in. We put in a new ball, and we put in a stem actually into the thigh bone. So these pieces are actually modular. So they come apart and they get put together in the operating room. And we have so much variability as far as the lengths and sizes that we have and different types of components. So we have a lot to choose from, and we can put them together in a way that tries to restore the anatomy. Now, when we were doing, say, like the posterior approach, we had to estimate whether we were putting them together in the correct length in order to make one leg equal to the other. Now, the benefit we have with the anterior approach is that when I'm putting them together, I can look and say, oh, you know what, I need to change the length of the neck a little bit shorter, a little bit longer in order to get it exactly to the equal to the other size. Or we need to take the component and, you know what, let's just move it down a couple of millimeters so it sits in this spot rather than that spot, which again tries to get the lengths to be equal. That's an ability that we haven't had access to before this.
I mean, besides the obvious, what's the importance of that? I mean, is it for health, life?
Patients don't like to have their legs be different lengths. They can tolerate a little bit, but if one of the particular problems that patients will feel, which is typical, is that the leg will end up becoming a little bit longer than the other one. And so they have to compensate by putting in an insert into the other shoe. If it's real bad, you may even have to build up the outside of the shoe. It throws off the way that you walk if one leg is longer than the other.
Affect the spine in any way?
It does. And a lot of these patients already have some spinal issues.
Right.
Their pelvis are a little bit oblique. They have scoliosis. And you can make these conditions more difficult to deal with if you don't get that as close as possible.
So really, what you're telling me is you can, when you replace the hip, it's now that with this new procedure, it can be done with less pain and less intrusion to the body and cutting of muscle.
That's right.
So, and then you can make the legs the same length, which is better to the quality of life when they're done. And then I would imagine the recovery time is better.
Exactly right. You allow patients to be up and walking immediately. Typically, they will have some less pain associated than with the more traditional posterior approach. And don't get me wrong, it's still a major operation. The patient still has recovery that they need to do, but it's an advancement for something that we didn't have before. Another benefit is that when we did the approach from the back or from the posterior, we would repair the tendon that we had to take down in order to access the hip. And we needed to protect that tendon for about 6 weeks because we wanted it to heal so that we could lower the chance of a dislocation of the hip actually kind of coming apart. And one way that we would protect that repair is we try to have the patient prevent them from putting their legs into certain positions. This is what we call a hip precaution. Okay, so specifically the patient wouldn't be able to flex their hip up past about 90 degrees and they couldn't rotate their leg in. And if you can imagine yourself in a toilet, you'll notice you kind of get into that position rather easily. So we'd have to change them over to have elevated toilet seats. We would put devices on their legs or even between their legs to prevent them from going into those positions. There's these big pillows we would put between their legs, or we put this brace on their leg to prevent them from going into those positions for about 6 weeks. Patients don't like to use those kinds of appliances after having a major surgery. It's difficult.
Yeah, I imagine.
And with the new anterior approach, we don't have to do that. We don't have to have the same kind of precautions that we did with the posterior approach. So they don't have to have the brace on their leg or the pillow between their legs, and we don't have to tell them be real fearful of putting your leg in this position or that position. That also helps them with recovery.
So Halifax has 2 of these tables?
That's right. They have one of each of the tables. One of them, which is the Hana table, which I mentioned, is really very specific for doing the anterior hip. And then we have another table called the PROfx table, which you can also utilize for the anterior hip procedure, but it also has the ability to do even other procedures, some complex pelvic reconstruction procedures. They're really multifunctional, and we have them both available to do these procedures now.
And in Halifax, I mean, so you have a team that works with you when you do the surgery?
Oh, that's right. There's multiple people in the operating room at that time. We have a team. We have sometimes an assistant surgeon. We have nurses that are in the room. We have techs who are with us, and we try to keep very similar teams together so that they know what we like to do. They can predict what the next step is. They can really make everything very efficient while we're doing the surgery. We have excellent anesthesiologists as well. So yeah, we have a real good, solid team.
Is it kind of an outside look in? It seems a common thing that I'm learning from talking to different physicians, as opposed to maybe in years past, there's much more of a team effort going on.
Absolutely. And that is not only in the operating room, because that is a huge goal of us in the operating room, but it's also on the floors. We have classes that patients will go to before surgery and learn more about the procedure that they're going to have, specifically with hip replacements. I have all my patients always go to the hospital and meet the nurses, meet the team that they're going to be seeing. They start to learn some of the details. This is the same people that take care of them afterwards. After the surgery, they're in the hospital on average about 3 days or so. We actually have a class that they will go to while on the nursing floor to meet other patients who have had similar procedures done, or who maybe have had a knee replacement done, and who are in the same boat as them, and they can socialize and they can reaffirm how they're doing and create an atmosphere that is real nice for the patients and the staff as well.
Okay, so when we get through the surgery, what's the rehab time now we're looking at with this new procedure versus the past?
Well, again, it goes in stages. The patient's up and walking immediately. They will likely use a walker if they're younger, maybe get quickly from crutches or to a cane. Very frequently, they will feel better than they did before surgery very fast, because that arthritic pain is gone. They notice it. They notice that groin pain that they had beforehand, that grinding, that stiffness, that goes away immediately. So patients actually with this procedure are very happy very quickly. But then they have to recover from the surgery itself, and that will take several weeks before they start to feel real comfortable. I still tell them it takes a couple of months for the full healing, but it happens in stages. And the nice thing is that with the new approaches, it kind of takes those stages and it moves them up a little bit. It makes those things happen a little quicker.
Yeah, and so then what are for those out there maybe contemplating that they need this surgery and the fear of wanting to go through it, what's the other side look like? What are they going to gain that they don't have now?
2 big things. They get out of pain and they have more function. And these are the things that we study as an orthopedic surgeon. We always look at, are the procedures that we're doing, are they helping patients? Are they good for patients? And we've studied hip and knee replacements in so many different ways, and we have found consistently over and over that we restore a huge amount of function to the patient. They can walk again. Some of these patients, they have trouble just getting out and going to the grocery store.
Right.
And or if they do, they're hobbling. They need to hold on to the shopping cart because they need to offload the stress off of their hip and get rid of the pain. One of the things that I hear from patients all the time is, my hip hurts and I can't sleep. It hurts enough that it affects my sleep, which of course affects everything else in your life. And you see them that once they recover, how happy they are and how they can really start to do a lot of things they couldn't do for years is actually really gratifying.
That's terrific. Now, if someone listening out there wanted more information, like what would be the next step? How would they get a hold of you or someone to find out more?
We have a lot of information on our website, which is www.orthodb.com. So it's the Orthopedic Clinic of Daytona Beach. That's where I am. So it's orthodb.com. They can call us directly if they want. We're 386-255-4596. Essentially, when someone comes in to see me, it's always a learning process. It's not just they're coming in because they need to have a surgery. It's coming in so that they can be evaluated to understand where are they in this situation, what are their options, have they done the conservative management options, or do we need to proceed to surgery and start to understand what these options are.
And then the last question, obviously, everybody wants to know cost-wise. I mean, is this something that most insurance carriers cover? Are there certain
Absolutely
points you've got to be at before they'll do it, or how's that work?
Well, it's a good question that you asked. That Medicare has started to create some restrictions as far as that concerns, as far as kind of the points that you have to do. They do want to see some time with conservative management, which is great because that really fits in line with the way we treat patients anyway. But for the most part, as far as costs, obviously that varies from insurance to insurance. But for the most part, this is covered. It's covered by Medicare. It's covered by all the major insurances. There may be some copays and deductibles that the patient needs to work on, but it's such a popular procedure that it has to be really covered by the insurance companies.
Great, Doc. Thank you so much for coming in and sharing that with us. I mean, I think that's great information because I know a lot of our listeners are themselves dealing with an issue, a knee or a hip that they probably need to do something about. And we all tend to procrastinate, right? We put things off. Isn't that what you normally see? People put things off.
You do, but you're right. Get in, get the evaluation, figure out what needs to get done, and then you can make an informed decision about what to do next. And I appreciate you giving me the time to
Absolutely.
To talk to your listeners.
Now, you told me that you like cultural things, so I'm going to put you on the spot. You like the Peabody Auditorium, I imagine.
Course.
You've been there, right?
Absolutely.
So they've got some good stuff coming on. In fact, Bill Cosby's going to be there tomorrow. They just finished up the Symphony Society, just got done with their season there. So they're one of our sponsors, and I always like to, to me, I don't know, being a New York guy, I mean, isn't that a cool building? One of the coolest.
Absolutely. Our clinic is a huge sponsor of
Right.
the Symphony Society, and think that it's just great to have that here in Daytona. Absolutely.
Right. Well, Brian Hatten, thank you so much for being my guest today. And Dave, I think we're about to get on out of here, and I've got one last song, another cut off of Southern Hospitality. It's another Victor Wainwright song called Don't Boogie Woogie.
I was feeling kind of poorly, hadn't been looking too fine, just had to find out what was ailing this old body of mine.